Naranasan mo na bang naglalakad ka? Tapos bigla ka na lang napuwing? Tapos pakiramdam mo, parang may alikabok na nakadikit sa mata mo na hindi nawawala? Nagluluha ka na, makate, o nagiging mahapdi na ito? Huwag mong kuskusin! Baka nagkagasgas na ang iyong mata. Tara, ipatingin na natin yan. Ang gasgas sa mata ay tinatawag rin na corneal abrasion. Ang cornea, ang pinakaharapan na parte ng iyong mata na tumutulong sa pagpapalinaw ng ating paningin. Maaari rin itong magkagasgas dahil sa kalamot ng kuko, hibla ng makeup brush, sanga ng puno, gilid ng contact lens, o mga kemikal. Pwede rin ito mangyari habang nagtatabas ng damo, nag-aayos ng kotse, nagpipinta, o sa welding. Kapag nagasgasan ng mata, maaaring sumakit, mamula, magmuta, maluha, maging sensitibo sa ilaw, o kaya naman ay manlabo ang paningin. Hala! Paano mo na masisilayan ang ganda ng mundo? Kaya kapag nangyari ito sa'yo, ang pwede mong unang gawin ay hugasan ang mata gamit ang malinis na tubig o saline solution kung mayroon. Kung mayroong malapit na eye rinse station, gamitin ito. IKURAP ng paulit-ulit ang mata para matanggal ng luha ang nakapuwing sa iyo. Pagkatapos, ay pumunta agad sa doktor upang matignan ng mabuti ang iyong mga mata. May ipapatak na pampamanhid at pangkulay at saka iilawan ng mata para mas maiging makita ang gasgas. Depende sa laki ng gasgas na makita ng doktor, pwede itong obserbahan lamang, bigyan ng pampatak para manatili itong basa at madulas, o pwede rin magbigay ang doktor ng pampatak o pamahid na may gamot o antibiotic. Huwag basta-basta gumamit ng mga pampatak sa mata na hindi inireseta ng doktor. Ang sobrang pagpatak ng pampamanhid ay nakakaginhawa ng sakit, pero baka hindi mo na mapansin na lumalala na pala ang kondisyon mo at nagkaroon ka na ng impeksyon sa mata. Upang maiwasan ang pagkakaroon ng gasgas at impeksyon sa mata, gumamit ng protective eyewear tulad ng shades o safety glasses. Maghugas ng kamay gamit ng tubig at sabon bago hawakan ng mga mata. Tanggalin lagi ang contact lens bago matulog at regular na linisin ito. Kung mayroon pang ibang kalagayan sa mata, huwag kalimutan na gamutin rin ito. Kapag lumala ang kondisyon, kumonsulta muli sa doktor. Ito ay isang paalala mula sa The Medical City Eye and Vision Institute at Batch 2021 Cluster 4.1. Salamat sa panonood! Naranasan mo na bang naglalakad ka? Tapos bigla ka na lang napuwing? Tapos pakiramdam mo, parang may alikabok na nakadikit sa mata mo na hindi nawawala? Nagluluha ka na, makate, o nagiging mahapdi na ito? Hep! Huwag mong kuskusin! Baka nagkagasgas na ang iyong mata. Tara, ipatingin na natin yan. Ang gasgas sa mata ay tinatawag rin na corneal abrasion. Ang cornea, ang pinakaharapan na parte ng iyong mata na tumutulong sa pagpapalinaw ng ating paningin. Maaari rin itong magkagasgas dahil sa kalamot ng kuko, hibla ng makeup brush, sanga ng puno, gilid ng contact lens, o mga kemikal. Pwede rin ito mangyari habang nagtatabas ng damo, nag-aayos ng kotse, nagpipinta, o sa welding. Kapag nagasgasan ng mata, maaaring sumakit, mamula, magmuta, maluha, maging sensitibo sa ilaw, o kaya naman ay manlabo ang paningin. Hala! Paano mo na masisilayan ang ganda ng mundo? Kaya kapag nangyari ito sa'yo, ang pwede mong unang gawin ay hugasan ang mata gamit ang malinis na tubig o saline solution kung mayroon. Kung mayroong malapit na eye rinse station, gamitin ito. IKURAP ng paulit-ulit ang mata para matanggal ng luha ang nakapuwing sa iyo. Pagkatapos, ay pumunta agad sa doktor upang matignan ng mabuti ang iyong mga mata. May ipapatak na pampamanhid at pangkulay at saka iilawan ng mata para mas maiging makita ang gasgas. Depende sa laki ng gasgas na makita ng doktor, pwede itong obserbahan lamang, bigyan ng pampatak para manatili itong basa at madulas, o pwede rin magbigay ang doktor ng pampatak o pamahid na may gamot o antibiotic. Huwag basta-basta gumamit ng mga pampatak sa mata na hindi inireseta ng doktor. Ang sobrang pagpatak ng pampamanhid ay nakakaginhawa ng sakit, pero baka hindi mo na mapansin na lumalala na pala ang kondisyon mo at nagkaroon ka na ng impeksyon sa mata. Upang maiwasan ang pagkakaroon ng gasgas at impeksyon sa mata, gumamit ng protective eyewear tulad ng shades o safety glasses. Maghugas ng kamay gamit ng tubig at sabon bago hawakan ng mga mata. Tanggalin lagi ang contact lens bago matulog at regular na linisin ito. Kung mayroon pang ibang kalagayan sa mata, huwag kalimutan na gamutin rin ito. Kapag lumala ang kondisyon, kumonsulta muli sa doktor. Ito ay isang paalala mula sa The Medical City Eye and Vision Institute at Batch 2021 Cluster 4.1. Salamat sa panonood!
Hi, good afternoon, everyone. Welcome back to our channel. It's 5 p.m. on a Thursday here in Manila, and you know what that means? Wala akong narinig, Ted.
Sir, just speak up, please.
I am your host, Dr. Alex Reyes, and with me is my friend, former classmate, and colleague from the Philippine Glaucoma Society, Dr. Ted Gonzalez. Wala akong narinig kay Ted.
Sir, just continue this.
Just read the next line, sir.
You're right, Ted. Thank you to all our subscribers, viewers, and of course, our sponsors for supporting TMC EyeTV from our first episode last June until now. To begin our program, let us listen to some words from our sponsor, Allergan. To give the opening remarks is the Business Unit Head of Allergan Philippines, Mr. Egbert Juson.
Thank you very much, Dr. Alex. I am Egbert Juson. I am the Business Unit Lead of Allergan Philippines. And I would like to thank the Medical City for having us partner with you for tonight's session. Tonight's session is actually episode 11 already of EyeTV. And I hope that tonight's session will be different from all your other sessions because it's going to be in a different format. It's going to be in a debate format discussing MIGS versus TRAB. So I do hope that aside from learning from the session, you're going to actually enjoy it. So thank you again for having us, and thank you for always thinking of Allergan AbbVie as one of your partners for patient care. And again, we are always committed for the improvement of our patients, and we do hope that we see each other again in future events. Again, in behalf of Allergan AbbVie, this is Egbert thanking you, and I hope you do have a good evening.
Today, we shall tackle one topic of particular interest, not just for us glaucoma specialists, but for all ophthalmologists in general. These topics are fairly common, but with the help of our glaucoma specialists like ourselves, our colleagues watching us this afternoon will surely gain useful tips in managing their own patients. Okay. A lot of innovations and technological advances are currently being developed in the field of glaucoma surgery. Are these innovations any better than what we've been used to doing in the past? In today's episode, we will listen to two perspectives on a procedure that's been gaining a lot of attention recently. We hope to answer the question that has been asked time and time again. When it comes to managing our glaucoma patients, should I do a trabeculectomy or should I do a minimally invasive glaucoma or MIGS procedure? Would that be more apt? Is there really a superior technique? This will prove to be a really interesting session. We have our colleagues to show us the intricacies of these techniques, as well as the advantages and disadvantages of one over the other. So without further ado, let's get to know our speakers for this afternoon. Our first speaker is not new to all of us or to EyeTV. He was with us when he hosted the 4th episode, and I must say he did a very good job. This afternoon, however, he's taken on another role in the program as he presents to us the basics and advantages of trabeculectomy in addressing patients with surgical needs. Will his side be the better option? We will find out as we welcome back Dr. Norman Aquino to our show. Norman is, of course, a founding member and past president of the Philippine Glaucoma Society. He's also an associate professor and chief of the Glaucoma Division of UPPGH. Finally, he's an active consultant at the American Eye Center and the Medical City. On the other hand, our next speaker will discuss why he thinks we must consider minimally invasive glaucoma surgery as a valid option to TRAB. We have with us Dr. Romel Bautista. Romel is known to be a motorcycle enthusiast, among other things. He did his residency training at the Medical City, after which he did his glaucoma fellowship at Stanford University Medical Center. He has been an active member of the Philippine Glaucoma Society. He is currently affiliated with St. Luke's Medical Center and the Medical City.
Can you hear me?
Oh, no.
Okay.
Yeah, we can hear you
Sorry
now, Ted.
kanina, nawala yung boses ko kanina.
Okay.
Okay, go ahead, Romel. Sino bang nauna? I think it's your turn, Alex.
No, Romel, I think.
No. So
Dr.
anyway,
Aquino first.
let's not wait any longer. Before we begin, I would like to inform everyone that we will have a short Q&A after this segment. So if you have questions for any of our speakers, please do not hesitate to type in your questions in the comments section. Again, let us all welcome Drs. Aquino, Bautista, and Rubio for their interesting lectures and presentation.
Good afternoon. I'm very pleased to be here. You know, I was not at all surprised that the older procedure was assigned to me, being the more senior consultant. That's all right. Let me assure the organizers that no offense was taken. Okay, I will now share my slides with you, and I hope I am okay in doing so. All right, I'm hoping you are seeing my title slide. For the next few minutes, allow me to highlight the most classic of all glaucoma procedures, trabeculectomy. My goal this afternoon is to convince all of you that this procedure is an oldie, but is definitely still a goodie, and that it continues to maintain its usefulness and relevance in the current management of glaucoma. Guarded penetrating filtering surgery, otherwise known as trabeculectomy, was introduced by Cairns in the 1960s. This means that this operation has been around for more than half a century and remains the most commonly performed glaucoma surgical procedure to this day. It is a relatively straightforward operation where an ostium, guarded by a partial thickness scleral flap, is created to connect the anterior chamber to the subconjunctival and subtenon space. The aqueous is eventually drained from the eye through the conjunctiva itself, the vascular and perivascular conjunctival tissues, the lymphatic vessels, and the aqueous veins. Filtering surgery must be considered when there is unsatisfactory control of intraocular pressure, putting a patient at significant risk for progression or visual deterioration. It is very important to take note into consideration the severity of the glaucoma, the target IOP settings, and the status and urgency of IOP control in each and every patient. These three are the most important factors to consider in deciding the best treatment option for any glaucoma patient. Having barriers to treatment, like adverse effects from medication, having compliance and sustainability issues, are also very valid reasons in considering doing surgery. And of course, the benefits of filtering surgery must always outweigh the risks of surgery. It is often said that the proof of the pudding is in the eating. So let us see how the trabeculectomy pudding tastes like. In the past, before all the current refinements came about, success rates were dismal at 60% at the very best. In the last 3 decades, with the improvements in microsurgical technique, anti-metabolite use, and a better understanding of wound healing and modulation, the results have dramatically improved. It is still not 100%, but it can go as high as 95% in the first year post-op. Large and landmark clinical trials like the CIGITS and the TVT study, or the tube versus trabeculectomy study, demonstrated very favorable success rates for those study subjects who were in the trabeculectomy arm of these studies. Lastly, and interestingly, there is a 20-year retrospective review that was done in the UK showing very good long-term results with trabeculectomy. In the performance of a trabeculectomy, there is extensive tissue manipulation and disruption. This is precisely why the quest for a better surgical modality continues. It would be very interesting for us to learn from Dr. Bautista later if the group of operations classified as MIGS would present as this better alternative to a trabeculectomy. I don't think I need to go through the long list of complications associated with this operation. I am sure you are all aware of the intraoperative events that can happen at the different steps of this surgery in the operating room, and the various post-operative problems, both early and late, that can occur after. We realize, of course, that trabeculectomy is not a very physiologic operation, and thus we run into problems as a result of it. To my mind, the proverbial Achilles heel of a trabeculectomy is how this operation can literally be destroyed by limbal healing and subconjunctival fibrosis. Keeping the filter working for the longest time is the biggest challenge any glaucoma surgeon will face. This again gives us another reason for looking for alternative surgical approaches. My fondness for trabeculectomy stems from its wide applicability. It can be used to address primary glaucomas, secondary glaucomas, glaucomas of the open angle or the angle closure type. It can be performed on patients as young as a relatively newborn with congenital glaucoma, all the way up to patients with adult onset glaucoma in their 80s. It is accomplished using your standard ophthalmic surgical instrument set. The usual cutting and tying instruments that we have in our set will do. If you want to go fancy, then having crystal knives and scleral punch is all that you need. No special lenses, no special sutures, no lives, no implants, and no stents are necessary to complete a trabeculectomy. Even in the operating room, a standard coaxial operating microscope will do. But you always have to remember that in the old days, this operation was possible using a high magnification loop. All things considered, trabeculectomy is an operation that is well suited for a developing or third world country like the Philippines. No fuss, nothing fancy, with fair to good results, and can be done under a mango tree. Personally, I find that being able to visualize every step of the operation, having the ability to control and modify events from start to finish, being able to test, have immediate feedback, and verify the results right on the operating table are the biggest reasons why trabeculectomy is distinct from other intraocular pressure lowering operations. Very much like doing phacoemulsification, you can see what is happening. You can adjust, you can apply remedial measures and do maneuvers. You can see the immediate results of all these. Oh, by the way, doing phacoemulsification alongside a trabeculectomy is not always necessary. I hear it is otherwise with MIGS. In trabeculectomy, the surgeon has full control in dissecting tissue planes, identifying anatomic landmarks. You know you have entered the AC when you see the aqueous gushing out. You have full control in determining the size of your sclerostomy. You can make sure that your iridectomy is wide, is basal, and is patent. You can control the amount of fluid that goes out of the eye by controlling the tightness of your scleral flap sutures. You are able to adjust anterior chamber depth and check the final IOP at the end of surgery. As you can see, with trabeculectomy, there is minimal guesswork and there is no need to cross one's fingers and hope for the best. Let me say that, however, that even after a technically perfect filtering surgery, it is still very possible that there will be unpleasant surprises awaiting you on post-operative day one. Such is the life of a glaucoma surgeon. What is good, however, is that many things can be done to remedy these surprises. When the IOP is high, you can manipulate the scleral flap by deforming it. To the residents listening, this is the so-called traverso maneuver. Sutures can be loosened or cut with relative ease. When the pressure is low and the bleb is high, we can easily deal with that. When the AC is shallow, we can also address that in the slit lamp. If there is any bleb leak, we can also try to remedy that problem. Antifibrotics are there to help us to modulate wound healing and promote success. You know, not too many operations offer this ability to deal with post-operative outcomes as quickly and as easily as a trabeculectomy. And that is, to me, a big, big advantage of this operation. So to conclude, I'd like to maintain that trabeculectomy remains relevant today and that there is enough experience and evidence to justify its continued use. As I said in the beginning of this talk, I do not want good old trabeculectomy to be buried under the glitz and glamour of the newer operations like MIGS. Please don't get me wrong. I am open to the prospect that trabeculectomy may be replaced by a new procedure for as long as there is better IOP lowering, greater safety, and higher success rates. What this new operation will be, when it will come, I don't know. Is it going to be one of the MIGS operations? I also don't know. So, you know, the next speaker, Dr. Romel, is a very good friend. And I would like to set the stage for his talk by posing the following points, which I am sure he will address. My first is, how cost-effective is MIGS? Will it give the glaucoma patient good value for money? And second, in the early days of MIGS, the surgeons with initial experience with it were saying that micro-invasive surgery was also micro-effective surgery, meaning MIGS did not bring down the intraocular pressure as much as they hoped it would. I therefore, like you, am very eager to hear from Romel if this notion and experience has changed today. So before I turn over the floor to Dr. Bautista, I would like to say thank you to the Medical City for having me, and thank all of you for your attention.
Can you see the screen, guys? Can you see the screen, guys? Okay, good afternoon. Sorry for that. I wasn't sure if you were actually seeing my screen. So today I'm going to talk to you about minimally invasive glaucoma surgery, otherwise known as MIGS. And it is actually the new surgical playbook for glaucoma subspecialists. These are my financial disclosures for the purpose of this talk. And a bit of an introduction. Minimally invasive glaucoma surgery, or MIGS, is a whole genre of minimally invasive procedures using proprietary devices or instruments designed to lower IOP by increasing outflow without resorting to the traditional filtration surgery. As you can see on the screen, there are many different types of MIGS. In fact, this is perhaps maybe just half of them. At last count, I believe there are about 12 or 13 different minimally invasive glaucoma surgical techniques that are all awaiting either CE, FDA, or local approval. They are also placed in different parts of the eye. For the trabecular meshwork, we have the eye stent, both the generation 1 or G1 and G2. We have the hydrus. We also have instruments such as the trabeculectomy or the hook blade to strip the trabecular meshwork off and allow access of aqueous fluid directly into Schlemm's canal. For the suprachoroidal space, we have the CyPass, which has since been withdrawn from the market due to significant endothelial cell loss, and the iStent Supra, which is currently CE approved and FDA approved as well. The subconjunctival space, which I believe is more of a match for trabeculectomy, we have the SEN and we have the pressure flow, formerly known as the InFocus. So why adopt MIGS? Well, first and foremost, there are limitations to medical management. As Norman earlier mentioned, there's always an issue of adherence and persistence over time. Obviously, the inconvenience of it, not to mention the side effects. And of course, continuous cost, because these medicines or these medications continue to be maintenance medications. As far as the limitations of traditional surgery is concerned, Norman has obviously mentioned that it is invasive. The recovery can actually be prolonged. And of course, being widely invasive, it can also be prone to a bunch of serious complications. So the general indication for MIGS are as follows. These are usually indicated for patients with poor medical compliance due to inconvenience, adverse effects, continuing costs, and/or progression. It also offers an alternative to treatment acceleration, either in the form of adding more medications or filtering surgery. The old dictum was that if a patient wasn't controlled with medications alone, then trabeculectomy would be next. The new paradigm is that MIGS inserts itself in between the two, thereby allowing another gear in the bicycle, so to speak, before we proceed to something a bit more invasive. The indications, as mentioned, are primarily for people with open angle, POAG, or pseudoexfoliation glaucoma, mild to severe damage, juvenile open angle glaucoma, NTG, or even failed glaucoma surgery. The contraindications are obviously angle closure, neovascular glaucoma in the closed stage, uveitic glaucoma, traumatic glaucoma, and congenital glaucoma. The features of MIGS, obviously, because it's minimally invasive, result with minimal trauma, extremely short surgical time, extremely fast post-operative recovery without hardly any change in refraction, and a relatively good or excellent safety profile, depending on the device you're using. The benefits of MIGS for the patient, obviously, is IOP reduction, reduce the burden of medications, improved ocular surface. I believe we are all familiar with OSD and how it impacts the eyes of people who are chronically on medications. And of course, avoid invasive surgery. But what about the physician? There are also benefits for the physician. For one, you're offering premium service and differentiate yourself from the rest of the pack. But more importantly, there's a great degree of satisfaction in increasing your surgical options, because MIGS does not preclude the performance of a trabeculectomy or even a tube later on, as you will see. Unfortunately, we only have 2 devices available in the Philippines at the moment. This is the iStent, the generation 1 and the generation 2, and of course the SEN. So let me talk to you about the iStent G1. This is the first generation iStent that we've ever used. It is extremely small, about 1 millimeter by 0.3 millimeters big. It is heparin coated to promote self-priming and to facilitate outflow. It is non-magnetic or non-ferromagnetic, thereby safe, even if implanted in the eye for patients who are about to undergo MRIs and stuff like that. It is rated to about 3 Tesla in that sense. Regardless of whether you're using a G1 or a G2, the concept is the same. It's basically it's basically a stent that makes a connection or a direct connection between the anterior chamber aqueous into the Schlemm's canal. This is one of the very first cases I did. I believe this is the second case. With a bit of pilocarpine and viscoelastic inside. You need to visualize the angle. As you can see, you can pretty much see the TM stripe. And here you are entering the eye. And the idea was to basically hook the trabecular meshwork and implant the snorkel inside. Here I am, I'm trying to find the right angle. You really should be going in at about maybe 15 degrees. But here, as you can see, I'm a bit too parallel. I'm just barely scratching the surface of the trabecular meshwork. I go for a more obtuse angle, and there you go. It's inside. The blood reflux is a good sign, believe it or not, because it basically tells you that you're already inside Schlemm's canal. This, the bleeding and the viscoelastic is easily aspirated. Here I'm putting a bit more viscoelastic and tapping the snorkel just to make sure that it's in place. And you're done. The iStent Generation 2 is the latest iStent to be marketed here in the Philippines and is widely used around the world because of the ease of use. It's a totally different design. As you can see, the conical part, or the hat, or the head, is actually the part of the iStent that actually goes inside Schlemm's canal. The thorax, or the waist of the stent, is actually what straddles the trabecular meshwork, and the flange is what you see inside the AC to confirm its placement. So this is fairly idiot-proof. Just make sure you've got a good view of the trabecular meshwork. Make an indentation punch, and then another punch. So the iStent 2 actually comes with 2 stents. And there you go. You see the aqueous flowing through the stents and into Schlemm's canal. The difficult thing about performing this procedure is that although the insertion is relatively easy and can be done by any glaucoma, any ophthalmic surgeon, is that you need to be proficient in positioning the patient in the microscope. To visualize the angle very well, you need to tilt the head of the patient by about 30 degrees and tilt the microscope as well. Another thing you need to remember is that for you to be able to visualize the angle very well, if you're used to doing phaco at about maybe 8x or 9x, you need to go about 13x or higher. Doesn't really take long for you to basically get used to this technique and holding the intraoperative gonio lens. So what do the numbers say? Regardless of, it's important to understand that the iStent has been around for about 8 years already, perhaps maybe even longer than that. And depending on how many, on which study you read, it will tell you that the average IOP drop is about anywhere from 3 to 12 millimeters mercury. And this was for the G1 when we only had 1 stent, but now the G2 already has 2 stents in 2 different quadrants. And the average number of drops eliminated was approximately 1 to 3. Now, we also do have local results of patients whom we actually did here in the Philippines, and we found out that our results pretty much mirrored what they found in other parts of the world. If you were to put an iStent solo, without doing any phacoemulsification whatsoever, we found that we got about a 28.4% IOP reduction with about a 50% medication reduction in these patients. For people who we performed phaco and iStent on in one sitting, the IOP reduction was significantly less at just about 9.5%, with a 55% medication reduction. The combined results put you in the vicinity of 15 to 20% IOP reduction, with a 54.7% medication reduction. That's for the G1. That's, I'd say, significant enough. At this point, I think it's important for everybody listening to understand that extremely low pressures is not feasible with the iStent, simply because you're at the mercy of episcleral venous pressure. The aqueous outflow in this particular minimally invasive glaucoma procedure is 100% dependent on your prevalent EVP floor, or episcleral venous pressure floor. If that is about 8, if that is 10, if that is 11, that is 12, that is the lowest that you can actually ever get with an iStent, because the exit of aqueous will still have to go through physiologic avenues. What about the iStent inject? What do the numbers say? Again, depending on the study you read, 80 to 100% achieved greater than or equal to 20% drop in IOP on 0 to 1 medications. 91% on 1 to 3 meds preoperatively ended up with greater than or equal to 20% IOP reduction with no meds for 3 to 5 years. Nuhan in 2020 described, reported a 25 to 26% IOP reduction at 12 and 24 months. Again, I'd like to say a few things that I believe are important at this point, and I wish that you would pay attention to them. When we performed the local study, meds weren't discontinued prior to surgery. There was no washout. Hence, the preoperative intraocular pressure should actually have been higher. And despite an average of 50% reduction in medications, almost 40% became medication-free post-stenting. And this was using the G1. Studies have shown that by using more stents, you actually reduce the number, you actually increase the amount of IOP lowering. And more importantly, IOP reduction isn't the only parameter that matters. We all need to remember that even if IOP ends up the same, the fact that medications were reduced or even eliminated or treatment acceleration was avoided is beneficial. And because of the size and anatomical placement of the stent, it doesn't jeopardize future filtering surgery should you need it in the future. And it doesn't affect the safety and outcome of cataract surgery, whether you do it in conjunction with stenting, before it, or after it. Now let's go to the SEN, which has always been labeled as a potential trab killer. A SEN is a device, a gel device that is implanted subconjunctivally or subtenons. Mitomycin C is needed, just like in trabeculectomy, and is capable of lower IOPs due to the absence of episcleral venous pressure independence. Bleb management can be crucial in a significant amount of cases, but not all. So here's a picture of the SEN. It's about 6 millimeters long with an internal diameter of about 45 microns. It is made of gelatin derived from porcine or pig dermis, formed into a tube and cross-linked with glutaraldehyde. So this might be an issue for patients who are actually Muslims, because this is derived from porcine dermis. So kindly keep that in mind. Here's a video just to put things into context for you. Small incision through the meshwork, through tenons. You tent up the conjunctiva, deploy the stent or the SEN, maintaining positive pressure. As soon as it's out, aqueous starts to flow. No opening of the conj, no suturing, literally minimally invasive. Now, this is an actual case that I did. I believe this is like the second case I did. So again, we put pilocarpine, viscoelastic. This time you don't have to tilt the head. You have a proprietary gonio prism that allows you to visualize the angle very well. Of course, you need a bit of gel to couple the lens onto the cornea. You try to hit the anterior trabecular meshwork, come out at about 3 millimeters outside of the posterior to the limbus. Here I'm deploying the stent, and here I am trying to make sure that it's under conj and it's actually free and mobile. And now I'm doing a gonio again just to visualize that it's actually in there, in the right place. And then, as you can see, you could immediately, just like in a trabeculectomy, as Norman mentioned, you could actually validate the results of your work because a bleb immediately forms. So what do my numbers say? I've done close to perhaps maybe 30 cases with the SEN, and I usually end up with single-digit IOPs in the immediate post-operative period. And that's most likely due to peritubular flow. As the SEN expands over time, it starts to close up the hole that the trocar or the inserter made. And the IOPs typically settle down in the low teens, usually about 10 to 14 millimeters mercury without meds. In my hands, with that particular technique, I found that I had to needle roughly about 30% of my patients, with or without 5FU. I had to perform one open revision due to a SEN extrusion that actually made a U-turn, which was repaired successfully. And I recently had to do a one open revision after 2 attempts of needling. A word on the IOPs. So you might say that, when you perform a trabeculectomy, it would be nice to have pressures below 12 or perhaps maybe even single digit. Yeah, that's true. That's great. But let me put it to you in a different way. It's fairly easy to spot somebody who is actually worsening on a particular regimen. Say, for example, you've got a patient on 3 medications and repeated visual testing shows convincing progression. That's somebody who's progressing and obviously needs to have his or her pressure lowered significantly. So in other words, a new target pressure needs to be established. But it's very, very, very hard to spot somebody with low pressures who actually might do just as well with a couple of millimeters higher in terms of pressure. So if a patient ends up with 10, 12, 13, 14 on a SEN, I'm happy. I'd like to end this lecture with a slide from Ike Ahmed, which was, I believe, given last October 11 in the WGA webinar. Again, it basically gives us a framework as to where these particular devices are applicable. And for mild to moderate glaucoma, whether controlled or not, perhaps maybe trabecular meshwork surgery is more apt. And for those who have moderate to advanced or progressive glaucoma with medium to heavy medication load, then perhaps SEN is the way to go, or SEN is the way to go. He continues to mention, however, that refractory or high-risk glaucoma is definitely in the realm of the TRAB or a CHU, which I take exception to because I have performed SEN operations, a few of them on people who have refractory glaucoma or high risk, and they seem to have done very well. And my reason for doing so is because the patient only had one eye, the patient was extremely young, and I would like to reserve the trabeculectomy for later. Thank you. That's the end of my presentation.
Okay.
Okay. Thank you, Allergan. After those 2 presentations, it would be great to see how Trabec or MIGS can be applied in actual cases which we manage in clinics. The last speaker for this afternoon will put the first 2 presentations to the test, as Dr. Carlo Rubio will be presenting some of his own cases for discussion. Carlo is a medical graduate of the UP College of Medicine. He completed his residency training and glaucoma fellowship at UPPGH. He pursued further training in the same field at the Singapore National Eye Center. Currently, Dr. Rubio is also an active consultant at Peregrine Eye and Laser Institute and St. Luke's Medical Center. Wala pa rin.
Wala ulit.
problema si Ted. Okay, well, we're having a problem, I think, with Ted's connection.
Audio.
Okay, so for this part of the program, let us welcome Dr. Carlo Rubio. And after he presents the cases, our two speakers and Dr. Rubio will give comments and views on how these patients should be managed. Without further ado, I now give the floor to Carlo.
So hello, good evening everyone. My name is Dr. Carlo Rubio, and I've been tasked to present two cases for which maybe TRAB or MIGS may be the appropriate option. So on purpose, I chose two cases which you could argue either way, depending on one, your surgical experience, and second, what the patient might want and what you might want for the patient. So the format is I will present two cases. So I'll present one case first. I will pause in the middle. I will show, and I will ask the speakers to discuss what they think is the appropriate course of action. And then I will show what happened. And I will do that for the first case, and I will do the same for the second case. So I will start sharing my screen now. So here we would like to discuss surgical dilemmas in open-angle glaucoma. So should we do TRAB or MIGS? So I have no financial interests to disclose. So some notes on the presentations. The cases are not clear-cut. So cases were chosen to spur debate. So you could argue that either MIGS or trabeculectomy may be applicable in this case. And I just want to clarify that both these cases definitely needed a phacoemulsification. So I also would like to note that my only experience with minimally invasive or microinvasive glaucoma surgery is with the Cahook dual blade. So the Cahook dual blade is a special incision device by which you actually incise a portion and excise a portion of the trabecular meshwork in order to expose the collector channels. I will show some videos later. So I would like to show two cases, and I would like to focus just on one eye for each case. So for the first case, we have VC, an 82-year-old male with Alzheimer's. So in the clinic, he wasn't very responsive. Sometimes he would respond, but sometimes he would not, and sometimes very sleepy, and basically hard to examine the patient. He is an hypertensive diabetic on a lot of medications, as you can see here listed. So here are the findings for the physical examination. So the right eye was just counting fingers at 1 foot, and the left eye was 20/200. However, the patient was not very cooperative due to the dementia. So the IOP was 31 on the right and 21 on the left. So this is both with no medication. So this patient came in with no meds at all. So gonioscopy showed 360 degrees open to scleral spur. It's open at the scleral spur with around 2+2 pigmentation. So slit lamp findings showed for both eyes, clear cornea, deep and quiet anterior chamber. For the right eye, we have an NO4 NC4 cataract with a thick posterior subcapsular cataract. And for the left eye, an NO3 NC3 cataract with a thin posterior subcapsular cataract. So for the posterior pole findings, we find on the right eye a nerve with generalized thinning around the CD ratio of around 0.9. But this was only seen through hazy media. And on the left eye, we have a nerve also with generalized thinning mostly superiorly and inferiorly, with this cup disc ratio of around 0.8. For both eyes, no other lesions were seen on the retina. So obviously, this is an intra-op picture, but I didn't have any pre-op pictures. So this is what the eye looked like. So after first seeing the patient, I did sequential addition of medications. For the right eye, I gave the patient latanoprost and brinzolamide plus brimonidine, and on the left eye, latanoprost. So I was actually avoiding timolol in this case because of the cardiac problems with the patient. I didn't want to risk any cardiac problems. So after giving the medications, the IOP decreased to 23 on the right and 13 on the left. So for the first case, we need to discuss, should I do a phaco-trab or should I do a phaco plus MIGS? So this is a relatively moderate to advanced glaucoma. Given the physical exam, I couldn't do a visual field test because the patient had dementia and couldn't cooperate, and I also couldn't do an OCT due to the hazy media. But generally, we can say that this patient has moderate to advanced glaucoma and needs low target IOP. So maybe a phaco-trab would be more appropriate. However, I was heavily considering doing phaco plus MIGS in this patient because this patient had dementia. So because this patient had dementia, I don't know, will I be able to examine the bleb appropriately afterwards? If I need to do a needling, will I be able to do a needling? If I need to do suture lysis or removal of sutures, will I be able to do those properly? And the wife of the patient also admitted that they had difficulty coming to clinic due to many factors. So after I first saw the patient, I only saw the patient 1 week, 1 month, and then 3 months after the first consult. In between, I did not see the patient at all. So bleb management might not be ideal. So I was heavily considering doing phaco plus MIGS. So with that, I will end my my presentation of the first case, allow for discussion, and I will discuss what happened to the case afterwards.
Okay, Ted. Wala si Ted. Okay, maybe I can just start the ball rolling. Maybe we can ask Dr. Norman, would you dare do a trabeculectomy in this case, where you may not be able to implement laser suture lysis, bleb massage, and all of that stuff?
All right. The first case had all the classic elements that would tell me that this patient needs a trabeculectomy. The amount of IOP lowering and all this stuff. But the modifying factors in the decision would be the general mentation of this patient, the inability to, follow up very well. And that is why it is a very good case to put up in order for us to determine what would be the best option. I mean, the arguments here is, all right, a mixed type of operation might have an advantage, but will it give you the IOP that you really need? No? So I am glad that the Kahook operation yielded pretty good resulting IOPs post-op. Yes.
Well, just as a follow-up to that, Dr. Norman, if you're going to do a trabeculectomy in this case, and
Yes.
you know that it's going to be difficult to do suture lysis or releasable sutures, how would you adjust the tightness of your flap? Will you be going for the, just the right tension, risking, how it is? You can go wrong either way.
That's correct. That's correct. I mean,
Or would you do what most people do? They tend to do kind of tight and then laser suture lysis or release.
well, Alex,
they
through
needed.
the years that
Would you modify your technique?
well, I will not modify my technique simply because ever since my technique in trabeculectomy was never a watertight scleral closing. The residents and the fellows who have joined me in the OR know that I have this preference for a slow ooze that through the years have allowed me to have pretty good success and control of my post-op. So I would go for that. I would not go for watertight. I would not go for very loose, but I would go somewhere midway that hopefully will allow me less post-operative manipulation in a 82-year-old Alzheimer's patient.
Well, Dr. Bautista, would you do a mix on this one? The very advanced glaucoma.
First of all, I think it's a misnomer to think that, as you correctly pointed out, Dr. Alex, that MIGS bleb management versus TRAB is very different. I would agree that as you learn the ropes of performing, say for example, MIGS in this particular case, perhaps maybe SEN if you're gunning for very low pressures, then yes, bleb management can be a challenge. But in this particular patient, even taking the visual field was already a challenge. So it begs the question whether doing a MIGS or doing a trabeculectomy would perhaps maybe even matter. I took note of the intraocular pressures of 31 on the right and I believe 21 on the left with no medications, which is a far cry from what we're used to seeing prior to doing trabeculectomy. Perhaps maybe this patient would have done well simply with a simple phaco and either a cahook or just put a couple of eye stents and be done with it. And not worry about releasing sutures or managing the bleb, etc., especially in light of the fact that, as Dr. Rubio mentioned, he was even having a hard time taking the visual acuity in the first place. So if I was, look, at 31, at 31 without any medications, 82-year-old patient with cognitive decline. I think, in my opinion, whether a TRAB or a MIGS would perhaps maybe be a difficult proposition for this patient. The most that I would perhaps maybe do for this patient is put a couple of eye stents or perform a cahook. And whatever residual pressure is left that I need to lower, depending on my target IOP, then I'm just going to ask his wife to just put the drops. The drops, whether with or without preservatives, is not going to affect the eye stent in any way.
Well, given the advanced damage, wouldn't you consider one of the bleb-producing MIGS?
I would, but
over an eye stent.
Over if I'm gunning for an absolute withdrawal, let me put it this way: if this patient did not have dementia, I would have placed a SEN. I think it's just more comfortable. You know, there's no change in refraction. The patient's not going to feel any sutures as he or she blinks. The recovery, we don't even have to patch the eye. We don't even have to do anything and basically wait for the pressure to go down. Should needling arise, and like I said, although the amount of needling is significant in my hands, up to about maybe 30%, it doesn't always happen. In fact, this morning, one of the residents was up in the clinic, basically referring a patient who I did MIGS on about 1.5 years ago. And this patient had a pressure of 24 without medications and has consistently, for the last 1.5 years, maintained a pressure of 11 on just one eye stent. I wonder how low it would have been if I placed a SEN. I also had another patient a while ago who followed up after, again, 1.5 years. I did his SEN in June of 2019. And the reason why I placed the Zen was because he was already splitting fixation, and he's just one of those guys. He's my age, he's busy, he always forgets to put his medications. So I said, perhaps maybe, and I saw significant progression in his visual field. So I said, perhaps maybe you're better off with the stent. And the reason I say that is because I did a trabeculectomy on him 10 years ago, which is still working, thank God. No? But
What happened? Sorry, I'm back, guys. Can you hear me?
yeah, we can. So this guy had a stent in June, I believe June 17 of 2019. I saw him on day 1, I saw him on week 1, and I never saw him again until today. And his bleb looks fantastic. No needling, no adjunctive 5FU, etc., etc. So it's a misconception to think that by putting sen, you're always manipulating the bleb, you're always injecting 5FU, you're always needling. It simply isn't true. It simply isn't true. So
It's hard to believe that worked, considering you must have had significant scarring already by then, Roman.
no,
Previous
sir.
trabeculectomy. So you're saying now that a previous trab would still be possible to do a sen?
No, sir. I'm talking about his other eye. I did a trab on the left eye, and then I did a sen on the right eye.
I see. I thought it was on the same eye, so it's a different eye.
Yeah. But now that you've mentioned
And how
it,
is the trab doing in the other eye?
it's still there. It's functioning. It's a little more vascularized than I'd like, but the pressure is 11, and the sen eye is actually also 11. So it was a tie. He was happy about that. I was happy about that because I was worried. You know, the guy showed up at day 1, week 1, and then I never saw him again after that. It's been a year and 4 months. And the bleb looks nice and healthy. It's maybe about 2.5 to maybe almost 3 clock hours. I see a bit of microcyst, which is a bit unusual for a sen bleb. You normally see that in trabeculectomy blebs or subtenons, but he had it. So I was quite pleased. I was quite pleased.
Okay, thank you so much for your input on the case. It makes me think about how maybe I should have managed the case, or maybe if I had the tools now, if I had the knowledge I had now for the previous cases. This happened around 2 or 3 years ago. So if you'd like me to, if I may, I'd like to continue discussing the case and show you what happened. So let me just share my screen again. Okay, so let me proceed. So this is what happened with this case. So I proceeded to do actually a phaco plus a hook dual blade operation. So let me walk you through the case. I might pause during the case and might rewind also, so kindly bear with me. So it was quite a dense cataract actually. So we proceeded to do the phaco emulsification. I usually do a pothole chop for my cataract. So thankfully it cracked nicely. So we completed the phaco emulsification, removed the remaining cortical material, filled the bag with viscoelastic, and implanted the lens. After which you need to inject the eye with more viscoelastic. So I want to pause in this slide because I wanted to show everyone what the hook dual blade looks like. So this is the blade, and this is the incising part of the blade. So you might notice actually that I'm using not the Swan-Jacob lens, which is usually the lens which is used for these angle procedures. This is because this patient is actually under general anesthesia because of the dementia and the Alzheimer's. So I actually had to do this using a different lens called a Mori lens, which allows coaxial viewing. You don't need to manipulate the head of the patient. You don't need to manipulate the microscope as well. Unfortunately, the view isn't as good as doing the angle surgery with a Swan-Jacob lens. So let me proceed. So we put the blade into position. So I like to pause here. So as you can see, the view is not as great with the Swan-Jacob lens. However, you can notice here that there is some reflux of the blood after the phaco emulsification, indicating where the trabecular meshwork was. So at this point, you make the initial incision. and then I flip the blade. Here, it's a bit more obvious here. You can see the trabecular meshwork here. And after you flip the blade, you try to complete the excision of the trabecular meshwork. So after which, like the case a while ago of Dr. Romel, where he had reflux of blood, you will notice that after successfully incising the TM, that blood does reflux into the anterior chamber. After which you do your usual INA and close up. So I would actually like to show another case. This is a similar case. However, this is actually an angle closure patient. So this patient, but this patient didn't, sorry, let me track back. Just a brief history, this patient did not, for some reason, did not want to, he was really supposed to be scheduled for phaco with trabeculectomy. But he begged me not to do a phaco trabeculectomy, probably because he couldn't come often for checkups. So I offered him, maybe we can try to do a phaco plus gonius seniculitis plus a Cahock dual blade. Maybe that would work, with no guarantees, of course. So we proceed to, this is after the phaco already. So we pursue, so the additional step here is performing gonius seniculitis with the Mori lens. And now that you've opened up the angle, so I'm opening up the angle even more, so you can see how different the view is with the Swan-Jacob lens and the Mori lens. So I'll show it again. So this is with the Mori lens. And you can see how much better the view is with the Swan-Jacob lens. So this is the lens I would suggest using for angle surgery. So after opening up the angle, you can see where the blood reflux is and where the blood is forming from the removal of the posterior synechiae. Afterwards, I proceed to do the, sorry for the view, but I think you can kind of see here where I do the incision, and then you can see after incising with the Cahock dual blade that there will be blood refluxing into the anterior chamber. There. So it is actually possible to perform MIGS in angle closure patients as long as you open up the angles intraoperatively. So day one, the post-op vision of the patient was just 2200, but this is still at least much better than the counting fingers vision. And it eventually improved to 20/150 at month 2. However, patient was still uncooperative with VA, but the wife did note that the patient did have clearer vision afterwards. So I want to show this slide also, emphasize this part. So day one, the IOP was 15, but I was thinking that maybe this also had some effect of the phaco, so I wanted to play it safe and added back 2 of the medications because we were aiming for low target pressures due to the advanced glaucoma. So on day 7, with aqueous suppressants, the patient's IOP actually went down to 12 on 2 medications. However, as was my fear, I actually had the patient come back another 1 or 2 more weeks so that I could monitor the pressure. As I had feared, the patient could not come back for checkup. So the patient is actually month 2 already when he came back. So thankfully, the pressures were actually 18 on no medications, which would tell me that if I put back at least 2 medications, maybe the pressure would go back to 12 or at least below 15. So unfortunately, this patient did not follow up again after this. And this was around 2 or 3 years ago. So since then, this patient hasn't even followed up again. So I'm kind of glad that I didn't have a bleb to worry about at this time. So the gonioscopy showed an open 360 to scleral spur. I couldn't really note if there was a cleft form because you expect a cleft to form after doing a Cahock dual blade, since at this point I wasn't really good yet at seeing patients with Cahock dual blade incisions. So the slit lamp showed clear cornea, deep and quiet chamber, and an IOL in place. So now I was able to definitely see the nerve, and it was really generalized, generally thin, and 0.9, showing an advanced glaucomatous nerve. So I'd like to proceed to the next case for discussion. So this is AT, a 62-year-old female who has a diagnosed case of CRVO on the left eye and POAG on primary open angle, central retinal vein occlusion of the left eye and primary open angle glaucoma of both eyes. So on the left eye, this patient actually already underwent 2 dexamethasone implants and 1 bevacizumab injection from the span of April 2018 to May 2018 for recurrent macular edema. So this patient is a businesswoman, hypertensive, non-diabetic. So the slight confounding factor in this case is that this patient regularly travels to North America because she needs to keep on going back every 3 to 4 months and stays for around 2 to 3 months for immigration purposes. So when I when the patient, this wasn't my checkup actually, this was just from the records, but at one point during her checkups, the patient's IOP on the right was 20, on the left on 28, despite being on brimonidine and timolol combination drops and tafloprost drops. So the referring physician added brinzolamide drops on the left eye and referred to me for glaucoma consult. So when I saw the patient, the findings were that the right eye was 20/25, correct BCVA of 20/20. On the left eye, 20/50, corrected to 20/40 with the following refraction. So IOP at that time was decent at this time, 17 on the right eye on 2 medications and 14 on the left eye with full meds. So gonioscopy, of course, showed open angles for both eyes. And unremarkable anterior chamber findings except for an NO2 and T2 cataract on the right eye and NO3 and C3 lens with a posterior subcapsular cataract on the left eye. Maybe contributing factor would be the 2 steroid injections on the left eye. So on the right eye was a generally normal posterior pole. On the left eye, we have generalized nerve thinning with a pale disc with a cup disc ratio of around 0.8. Macula is flat with attenuated vessels. So remember, this patient had a previous central retinal vein occlusion already. But at this time, since the occlusion occurred 2 years ago, a year previous to this, there are no more hemorrhages or exudates. So this is what the cataract of the case looked like. Again, this is an intra-op picture. I didn't have any pre-op pictures, just to show you an idea of, give you an idea of what the case looked like. So again, points to discuss. So would you do a phaco plus MIGS in this case? There are wide open angles in this case. Perfect for doing a MIGS procedure. However, this patient travels frequently, months at a time. So due to the concerns with bleb management, maybe it's a good idea for this patient not to have a bleb. So unfortunately, this patient might still need drops. And I failed to mention this, but this patient actually had mild intolerance to drops. So if you had to do a MIGS and put the patient back on meds, maybe the patient might not be happy about having to go back on the medication. So would you consider doing a phaco-trab? Since this patient has moderate to advanced glaucoma, confounded by the CRVO, of course, and due to the mild intolerance to drops, so because the phaco-trab would give the patient the best chance of not having to put any glaucoma drops anymore. And of course, we will have generally better IOP control with a phaco plus trab. So I would like to open up this case again for discussion.
Can you hear me, guys?
Yeah.
Okay, good. What was the reason for the dexamethasone injections, Carlo?
For the recurrent macular edema due to the previous central retinal vein occlusion, yes.
Okay, and that was how long ago? 2 years ago?
The patient had the attack of the CRVO April 2018, and I saw the patient July 2019, and in between around 1 month and maybe a few months after that, she had the dexamethasone injections for the both eyes.
But the pressure was elevated prior to the injections. It's not the steroid responder?
I think it's a mix, sir, because even the other eye, which I think there's also an element of steroid response because the left eye pressure is definitely higher than the right, but even the right eye had to be controlled on medications.
Okay.
So I think we might be looking at a POAG confounded with the possible steroid-induced glaucoma as well.
So let's hear from the guys.
Nothing works. Dr. Norman, wala yata tayong panalo dito. I mean, whether we do a Trabi or a Sen, perhaps, and we all know that whether you do a Trabi or a Sen, you're going to have to be on steroids for a significant amount of time. So Another issue is the fact that this patient has recurrent.
Well, Dr. Bautista, maybe I can ask which, if you were to do MIGS for this patient, which MIGS would you choose
I would choose a
and
stent.
why?
I would choose a stent because number one, the lumen of the stent at 45 microns in diameter practically makes hypotony non-existent, at least prolonged hypotony. As soon as the peritubular flow stops, then the hypotony stops. Another is if the patient has recurrent cystoid macular edema, perhaps maybe single-digit pressures won't really be too good for this patient. You know, it would be perhaps, in my opinion, better if the pressures were not 5 or 6 or 7. You know, also. Should the patient be requiring more injections in the future, I would prefer that I would prefer a smaller wound, if any, in that particular eye.
So what's your target pressure for this, Dr. Bautista?
I haven't seen the field, but if her cup disc ratio is 0.9 and the other one is 0.3, Carlo, tama
Yes,
ba?
sir. I'm generous actually, halos 0.95 na siguro yan. I think she had fields already. I was able to get it, but the fields are already almost tunnel vision. I mean, confounded, of course, by the previous retinal vein occlusion also.
All right. Well, then
Let me just stick with with my assignment tonight, and that is to defend trabeculectomy. All right. So this particular case, I have no problems doing a trab, despite the fact that she leaves the country every now and then. My only concession would probably to schedule her trab, 2 or 3 months before she leaves again. That will give me time to look after it. Okay, I wouldn't want her to ride a plane a week after I do my trab. Right? So for that worse eye, because of the pressures that I would like to achieve, I think trab is the best bet. My question to you, Carlo, is: are you not considering a MIGS on the other eye? You have a 0.3 cup disc ratio maintained on 2 medicines. That to me is a more ideal and clear-cut situation wherein any of the MIGS might work.
Okay. Excellent point, sir. Actually, I brought this up so that I could get your opinions on the case because she's
Libre konsulta, ha?
bumabalik, sir. So yun nga, buti na lang. I mean, buti na lang napapag-usapan natin. But you bring up a very good point, sir, about the timing. Actually, in fact, I will talk about this later, but we did take that into consideration that if we were to undergo a trab, that she has to promise me that she has to leave by this date and I have to operate you by this date. I think some other, yes, go ahead.
No, I agree.
Would you consider removing the cataract in the better eye when you do your MIGS? If you do your MIGS, for example, would you do it in one sitting?
So this is to me or to Dr. Bautista?
Yeah, either one of you. I mean you, Carlo.
I'll go ahead, Dr. Bautista.
Would you go ahead and remove the cataract, considering that he can still see 2025, 2020?
No, I think you can safely, as I showed you in the slides a while ago, our local results involved patients who received MIGS, regardless of whether they were phakic or pseudophakic, or had the MIGS at the same time, done concurrently with the phakic emulsification. At 2025, there's no reason to, there's 2025, 2020, there's no reason to remove the cataract. And putting a MIGS, regardless of what it is, I don't think is going to play a dramatic role in the outcome of your phakic emulsification.
Are there studies to show that there is no increased incidence of cataract progression after MIGS, Dr. Bautista?
I would imagine that any particular manipulation inside the eye has the potential to accelerate cataract formation. But I will tell you this, Dr. Ted, I have placed stents in people who are faking, simply because they just didn't have it. They didn't have a cataract.
Okay.
And I did not. I've been following up these patients for months on end, and I have not seen any progression in cataract formation. One of the things that perhaps maybe we should all keep in mind is that when we do angle surgery, we're always trying to constrict the pupil prior to inserting the device, which makes it safer. We're always deepening the chamber with viscoelastic, but prior to that, we're always giving pilocarpine or myostat to constrict the pupil, therefore minimizing the chance of hitting the lens.
Okay. Can you comment on the first case where you did, MIGS in a patient who had closed angle? What's the feeling of the group about that?
My case?
Yeah, whoever.
Carlo, was that you?
Yeah.
Yes, yung phaco with conjunctival silicolysis plus Cahock blade. I think we're just getting the opinion of the group about should it be done, should it be not. I was kind of pushed to the wall because she absolutely didn't want to have a trap done, but I knew I had to lower the pressure somehow. And without over-promising, I said that, okay, let's try it and see what happens. So would you do it in that case, or would you just not do it, or push for the trap?
I think to do phaco, GSL, and then mix all in one setting is a bit ambitious. In the first place, GSL in and of itself is going to make your anterior chamber prone to RBC infestation, and therefore make your view of the angle structures very poor. It's going to be a long surgery. It's going to be a tedious surgery. In short, it's just going to be a very, very ambitious surgery. I can't say it can be done, but I think that's pushing the limits of what we need to do for our patients ethically and perhaps maybe our surgical ego.
The point I'd like to make is, the whole concept of MIGS is trying to approximate natural drainage in the eye, all right? And with a Cahock blade, you're trying to just have the aqueous enter your drainage system a little better by removing your anterior wall of your Schlemm's canal, all right? But, as compared to a filter, you make a non-physiologic new opening. So in case one, this case is angle closure. I am just afraid that non-flow of your aqueous as a result of the angle closure has already somehow affected the natural pathways within the eye. So even if you remove that anterior segment of your trabecular meshwork, down the line, the pathways also might not be functioning as they should be. I mean, not unless the angle closure was maybe within a few weeks or a few months, there might be a chance to salvage that. But if it has been there and no aqueous has been flowing through those channels, it might not bring you back to the old physiologic drainage that you have.
In other words, you wouldn't have done
which brings us to your point, Dr. Norman.
Yes.
Trabeculectomy, in my opinion, has and will always have a role in glaucoma.
Correct.
And this is a prime example of it. I mean, if the angles are closed, then we're not talking about any other kind of mix. Regardless of if you can't visualize the angle structures, then there's no point. We go straight to trabeculectomy.
Correct. I have always maintained that, MIGS and traditional trab, they're not really opponents, all right? There is a role for one operation. There is a role for this other group of operations, depending on the goals that you want to achieve, depending on the current situation you have with your patient. So it's not really a fight of which is better. I think it is more of determining which patient will benefit more from whatever kind of operation that you deem to do.
Which brings up the question.
I just would like to
Go ahead. Yeah,
Sorry,
I'm wondering whether would you teach MIGS now to your residents? Would you allow them to do it? Or would you say that they have to practice TRAB first and then do MIGS when they're in private practice? How would you go about it?
I think as far as MIGS is concerned, from what I've seen from all the other MIGS, perhaps maybe the only type of MIGS that perhaps maybe a general ophthalmologist who regularly performs cataract surgery should be performing really is the eye stent. The SEN is in the purview of glaucoma specialists, and therefore MIGS in general, in all of its entirety, everything that's available to us should be taught to our fellows.
To fellows in glaucoma, but not the residents in ophthalmology.
No.
Okay.
It's not a requirement. I mean, they see us, they see me, they see Dr. Alex when we perform these procedures, but it shouldn't be part of the PBO board exam. If you ask me. But
theoretically, TRAB is actually a more complicated procedure if you really think about it.
Actually, yes. It is. But the thing about, and this is what I would like to address, Dr. Norman, in perhaps maybe his last few slides, was raised the question of cost effectiveness. And perhaps maybe this is the reason why we really should be teaching it to everybody, because these devices are fairly expensive, as opposed to, say, Europe and the United States, where, yes, they're even more expensive, but then again, Medicare takes care of, the insurance takes care of the device. But let's pause for a moment and do the math. If, say, for example, you're a candidate for filtering surgery, regardless of whatever filtering surgery you need, for you to be a candidate for filtering surgery, you should probably be on at the very least 2 medications, right? For you to be even considered to have filtering surgery. So if you're on 2 medication, it stands to reason that perhaps maybe you're roughly spending about two grand a month on medications, right? So 2,000 pesos times 12 months, that's 24,000 pesos. If I can make your MIGS last for at least 2 years, then you paid for the device. And now that we're seeing more and more studies coming out, 2 or 3 years ago, we were only seeing studies that had about maybe a 24-month follow-up, a 12-month follow-up. Now we're seeing a lot of MIG studies coming out with 5 years follow-up, 4 years follow-up, 3 years follow-up, and they're all very encouraging. So if I can buy you 5 years being medication-free and making your cornea and conjunctiva rest for 24 months, I think you basically paid for the device.
Romel, I'd like to ask, with what you have just said, where does selective laser trabeculoplasty come in? I mean, selective laser trabeculoplasty can defer surgery for a couple of years. It can spare them from medications for a couple of years. So give me a cost analysis of MIGS versus laser trabeculoplasty.
That's a very good question. I'm not a big fan of SLT. I've tried it many times in the past, and for some reason, before the year ends, I always get this upward drift. I don't know if it's me, my technique. I really don't know. But MIGS appears to work better in my hands. Now, having said that, it also goes to the point of perhaps maybe how much private practice is charging for SLT. I hear all sorts of figures, and I'm sure so have you, And I've heard doctors charge as much as what perhaps maybe a MIGS device will cost. If there was no monetary consideration to consider or to entertain, then if SLP works best in your hands, if you just want to make the lessen the amount of medications, or perhaps maybe prevent the addition of another drop, because the cornea is already red and it's the patient's already complaining of discomfort, etc., etc. Then certainly, if SLP works well in your hands, then certainly it is in and of itself a form of MIGS, isn't it?
Correct.
So
I have a feeling Alex does not agree with this. What do you think, Alex?
Oh, my
Alex,
sound was.
You've been very quiet.
I couldn't follow the conversation. My sound went off.
Okay.
Sorry.
Okay.
Uh-huh.
Yeah, but yeah.
Well,
So
I heard something
SLP
about
is a-
cost effectiveness.
Okay.
Personally, I really like the idea of MIGS, especially yung SEN, because trabeculectomy has these complications that sometimes come up. You wind up with low pressures, high astigmatism, etc. So it's a high pressure thing to do, in a patient who has good visual acuity afterwards. Whereas you do a MIGS, a SEN insertion that goes well, just takes a few minutes. There are no stitches. The hole is uniform, and it's almost like in some ways comparing phaco to ECCE,
Yeah.
in terms of
That's why I asked
post-operative
earlier,
comfort.
Alex. That's why I asked earlier, Alex, would you teach it to your residents? Because it's probably an easier thing for them to learn if you really think about it. And if they're doing phaco
If they can
anyway.
get their hands on the device, why not?
Okay. So it's just a matter of cost. But otherwise, technique-wise and for indication, it's all right.
Well,
right?
Personally, there's a steep learning curve for SEN, for me anyway. There are tricks to it, but yeah, it's one of those things that you get better at the more you do, I guess. Like phaco.
What's interesting, guys, is the fact that we're all familiar with the SEN being inserted ab internal, and then the gel stent ends up subconjunctivally. And there's a growing trend now of actually opening up the conj, similar to a trabe, but perhaps just 2 clock hours, dissect it all the way to the scleral bed, and then insert a 30 gauge needle, and then insert the SEN. So it's an ab externa insertion, and then you suture the conj. So very similar to trab, but this time without the scleral flap, without the punch, without the iridectomy, etc., etc. Yeah. But what I love about
I guess
yes, you put
the big variable in SEN insertion is where exactly the tip of the SEN
Goes out.
winds up. Ideally, it should be between above tenons but below conjunctiva. But it doesn't always end up that way. If it ends up tangled in the tenons, then your result might not be so good. So yeah,
Alex, the ab externo approach with the Zen offers you better control because you know where you will insert.
It.
Yeah, but
I've never tried it, but I kind of like the idea because there doesn't seem to be. I mean, I've seen failures of SEN, and what I see is a very, very strong fibrosis around the tube. Okay, you won't see it outside. Everything looks pearly white from outside, but if you open it, there's something wrapped around the implant itself. So which makes me wonder how much this avoiding cutting the conjunctiva really gets you. Maybe it's better just to open it up, just to make sure it's in exactly the right place. But that's something that we'll see, trials and all of that. Experience of people.
Actually, Dr. Norman, that is the whole principle of pressure flow or in focus, the product of Santen. It is actually an ab externo insertion, but this time again, no flap, no punch, no edit. And then you basically insert a tube with a fin to keep it stable in the tunnel, and then you basically close it up. What's nice about these things? What's nice about MIGS? What appeals to me so much, other than the fact that it's a relatively quick procedure to perform, is the fact that it does not preclude or it does not negate future glaucoma surgical interventions. If I do,
I'm not too sure about that though. Looking at the degree of fibrosis around the sen when it fails, you will induce quite a bit of fibrosis. It's not a free procedure, you know.
But if I were to say, for example, if I were to put an eye stent in the trabecular meshwork, or if I were to do a cahuco on the trabecular meshwork, if I'm not happy, if I don't reach target IOP, I can always go back to a trabe.
My impression really is that eye stents and maybe even cahooks, they're not really for the same indications as trabec. My impression is that patient is getting a phaco, they're on 1 or 2 medications. Hey, let's try this so that we might be able to get out. You may be able to get rid of your meds. And in setups where the device is paid for, it sounds like a very good proposition. But that's really a different situation as when you're doing a trabeculectomy. Trabeculectomy is something you'd rather not do, you know, generally.
Yeah. Okay, so
that's the nice thing about MIGS, no? Maybe they would give you really a third option, no? Before doing trabeculectomy. They might induce you to be a little bit more aggressive in offering that approach, the surgical approach.
now I'm thinking from the point of view of a general ophthalmologist, since they haven't trained for it, and they probably don't have the proper equipment to go for it. So sooner or later, they just have to really refer these patients to a glaucoma specialist. So the discussion is really more of interest to glaucoma specialists. What do you think?
For
Norman.
Yeah, I mean, in connection with your first question earlier, if this is going to be taught, this has to be taught to the glaucoma fellow, not to the ophthalmology resident. So if the general ophthalmologist feel that this patient can benefit from a MIGS, then that patient will have to be referred to a glaucoma specialist who has experience with MIGS.
But eye stent is supposed to be something that you would do when you're doing phaco in a patient who has some medication. So a general ophthalmologist theoretically should consider being able to do it.
A general ophthalmologist with very good training in gonioscopy. All right? that doctor will have to know.
I don't think it's our part to say what a person can or cannot do. Let them find out if they can
the
do
hard way.
The hard way, if they want to.
Yeah.
Yeah, it's so small. I've implanted, I don't know, and I've lost 2. I've lost 2 eye stents in the OR. It's so small. The minute you lose it, you lose it. It's so small. So there you go. I remember the first time I lost it, the nurse pressed the injector and basically released the stent, and we were all doing this, and of course you can't find it. So there you go.
So who pays for that, Roman?
I do. I do. Or in that case, actually, it was one of the early cases. So it was actually Dil Jacob who paid for it. Yes.
Well, now I have a question regarding the case you presented, Carlo, where
Yes.
you were successful in opening up the angle, and basically you decided to do the knife, right? The kahook knife. Would you have
Yes.
thought of placing a sen in that situation? Anyway, the angle is visible. Why not put a sen in that situation?
Theoretically, yes, but this patient really didn't want a bleb for some. I explained to him what a trabeculectomy was. He didn't want to deal with a bleb. I think this patient was from Boracay, who is also runs a dive shop. I think that's the reason why he absolutely didn't want to have trabeculectomy done or any bleb procedure done. I think that's the reason why I really wanted to do a trab actually in this patient. But I think taking those factors aside, if he didn't want a trab, but that bleb is not that big of an issue, maybe I think I would have done I haven't done a Zendo, admittedly, but that would be a very good option actually for this patient. Much better than the one I did, which is to do the Kohok blade. It's really put to the wall, but otherwise,
It actually opens a whole new
I might have
world
done the Zen. That's a good suggestion.
as far as angle closure is concerned. If you can do gonius endocytosis and you can see portions of the
Discuss ko pa
trabecular
ni Dr.
meshwork,
Ruby yung ginawa
would
niya
you,
sa phase
Rommel,
2.
think of putting a sen in that situation? Would that be something you'd consider doing?
In that particular patient who dives in Boracay and is always in the sea all the time, I don't think having a bleb of any sort, either from a sen or a trabe, would make a lot of sense, because it's like asking for a blebitis of some sort. But if that patient was wait, Carlo, tama ba? Did I hear you right? It was the first patient, the 82-year-old with dementia.
I didn't actually present the case. This is the case who had I just showed the video that you can do angle surgery after you open up the angles, after doing gonius endocytosis. I didn't actually present the case. I just showed the video and explained why I did it. Yeah.
I see. Yeah, well, again, to Alex's point, it really all depends on your target pressure. Minimally, I mean, eye stents would definitely be dependent on physiologic aqueous outflow and therefore be restricted by the level of the epithelial venous pressure, whereas subconjunctival mixed devices such as the pressure flow or the stent will not be. So therefore, you expect lower pressures with these devices. If you think that target pressure is achievable with the simple kahook or an eye stent, by all means do it. But if you're gunning for lower pressures because of extensive nerve damage or field damage, then obviously go for a stent.
We do have a Q&A after this. Maybe Carlo can tell us what he did.
So let's proceed with the case. So I'll try to make this fast. Time for the Q&A. So in this case, I actually decided to discuss with the patient. Can you promise me to? So let's plan out your timeline. When are you leaving? I'm leaving in September. Okay. So I said, can you do the surgery in July? So she said yes. So at least that gave me around 3 months to check the patient. So we did go ahead and do a phaco trab. So this is a very quick video. So we proceed to do the phaco part first. Proceed to do the phaco part first. So just the regular steps of a trabeculectomy, of phaco emulsification. So after the phaco emulsification is done, so we do the remove of the nucleus and the remaining epinuclear and cortical material. After this, we implant the lens. And after implanting the lens, it's important in phacotrabeculectomy, I generally suture the wound. And as you see, I filled the eye with viscoelastic. Because we will proceed to do the trabeculectomy afterwards. So I always suture my wound site because we will do the trabeculectomy and we don't want the AC shallowing too much. So as you notice, during this part, I actually include the mitomycin in the injection. So I feel like it's safe to put the mitomycin, inject it along with the lidocaine and epinephrine, even if I did the phaco, because there's anyway there's gel inside the anterior chamber, and I'm trying to inject it intratenons and not subconjunctival, so that the tenons would act as a sponge and hopefully not let the mitomycin leak out. So afterwards, we do the peritomy, do hemostasis, create the flap. I pre-place some sutures, enter the AC, proceed with the enter the anterior chamber, do the sclerostomy and the PI. Check for flow. If you're happy with the flow, then close up. So afterwards, this patient, 3 weeks post-op, she had some improvement of VA. As you will notice, the VA is still not as good as the VA pre-op, but she did say at least that the scattering of light from the posterior subcapsular cataract was now gone. So after doing a phacotrab in this patient, IOP 3 weeks post-op was 14, with clear cornea, deep and quiet anterior chamber with PCI well in place, diffuse mid-rise, fairly vascular bleb, C4M4H2V2 by Moorfield's grading. And posterior pole, now that I have a clear view, did show a generally thin nerve with 0.9 cup disc ratio. And the macula at this point looks flat. However, 6 weeks post-op, the patient presented with a drop in vision, and IOP was 12. So we were already suspecting that, oh no, maybe the macular edema recurred. So afterwards, I referred to the retina specialist after having done the OCT, and true enough, the macular edema did recur, and she needed another intravitreal bevacizumab injection. So at this point, the patient actually had to go to Canada already, and I haven't seen her since then. But the patient did mention that she has a doctor there that she can see. So just some general tips about MIGS. So it's a must that you master gonioscopy. Please try not to do MIGS if you haven't mastered gonioscopy yet. So watch surgical videos, attend wet lab courses. Although this may be difficult at this time. So what I did before doing these MIGS procedures is that I actually practiced using the gonio lenses during routine cataract surgery, even if the patients did not require having MIGS done, just so that you can have an idea. Because doing a gonio on these patients with physiologic conditions versus after doing phacoemulsification is actually different. So this is also discussed. So patient selection is key. So sometimes MIGS is the best option, sometimes TRAB is the best option, sometimes it's a gray area, and that's something that you just need to discuss with the patient. And if you do proceed to do MIGS, don't overpromise with the results. So thank you for your attention. I will stop sharing my slides now.
Okay. So that's it. Are we discussing this case? I think we've discussed it already.
Yes.
Maybe we have some questions from the audience now.
Yes.
Oh, yes.
Does the shape and size of the scleral flap make a difference in effectivity and longevity of function of the trab?
I suppose that's mine to answer, all right? It has been proven that shape doesn't matter. Whether your flap is triangular, whether it is square, whether it is trapezoidal, it doesn't matter. What is important more is the thickness of that flap, because that has a role in determining how good the flow will be. Of course, coupled with the fact that you have to adjust your tightness of sutures also to help control that flow. And that is why doing adjustable sutures has become very popular, because it gives you that option to modify your filtration post-op.
What about
adjustable or
you don't
releasable?
agree with the...
Sorry, you are breaking up.
sorry.
That's all right. That's all right.
Norman,
Alex, all right.
do you agree? Sorry. Norman, do you agree? You don't agree with Dr. Fenkau? He teaches that the flap should be fairly large to allow to encourage a fairly diffuse bleb as opposed to a small flap, which might give you a small bleb which can leak and all of that.
Honestly, I
Large
think
flaps for diffuse blebs, actually.
the flow is basically a function of the size of the sclerostomy, the tightness of the scleral flap, rather than the size of the flap itself. And I think trying to achieve a diffuse bleb is secondary to very good watertight closure of the conjunctiva, and of course the application of your mitomycin C. All right.
How about the number of sutures that you make to close the flap? Does that make a difference?
Probably not, as long as your endpoint is very clear to you. As you reform your anterior chamber with fluid through the paracentesis, then you can assess how much fluid is actually getting out of your eye and seeing if your chamber is shallowing or not. So that will be the main guide in having to add sutures, or the main guide in having to tighten any sutures that you already have. That is my personal thing that I do on the OR. Yes.
Well, I think if you survey glaucoma specialists, you'll see all sorts of variations of technique, which is one of the reasons why the SEN interests me. You'll wind up with a fairly uniform, less variables. You stick it in, no variables on how tight, how big your hole is, etc., etc. But we'll see how much that really matters.
You know, by the same token, Alex, I have always been a fan and have quite a bit of experience with the express shunt. You know, it is not traditionally included in the list of your MIGS operations. It is like a pseudo MIGS operation because it is bleb based, it is ab externo, but again, the size of the lumen of the implant allows me pretty good control and gives me a lot of confidence that when I insert it, I don't induce too much hypotony, nor do I flatten the anterior chamber too much. So even up to today, when I have to deal with toxic retina patients from my retina partners, and I have to do some sort of filtering surgery rather than doing a traditional trabeculectomy, it is the express that becomes my go-to operation.
But do you achieve enough pressure lowering in all the cases that you've managed?
Surprisingly, yes, Ted. Yes.
Oh, okay.
Yes. Yes.
Because that seems to be one of the limitations of that particular device, that there seems to be, you can't really get the low teens that you usually could get with Trab.
Well, maybe I have been lucky.
Okay.
Yes. Yes.
Okay, can we have the next question?
SEN appears to be a standardized procedure with uniform hole, no stitches, which can be too tight or too loose, etc. Does this translate to a more comfortable and predictable early post-op course, perhaps with less risk of vision quality, reducing hypotony and high astigmatism, faster recovery of vision, etc.? What do you think, Roman?
With regards to the comfort, hands down, it is definitely more comfortable post-operatively. And we hear this over and over again. In patients who have had a previous trabeculectomy in one eye several years ago and then underwent a SEN on the other eye, the difference to them is night and day. In fact, there is so much pressure when you start talking to patients about minimally invasive glaucoma surgery, in particular SEN, simply because of the cost of it. You want to make sure that it works. So you spend a lot of chair time with these people, and normally I normally tell patients to basically go to YouTube and watch Sen implantation and trabeculectomy implantation, and then they come back and say, "Doc, I choose the Sen." You know, I remember. I don't know if he's here. No, our chief resident, si Pluto, is here, I think. I remember doing the majority of my cases with her. She sat down with me for my first case, I believe, up until, I don't know, just a few cases ago, when she unceremoniously just tossed me up to her boyfriend, so to assist me. Pluto, I remember Pluto saying, "Sir," after seeing how Sen was done, she said, "If I ever need filtration surgery, I would want a Sen."
Yeah.
But going back to the question, post-operative course, yes, definitely not so much change in refraction. If ever, perhaps maybe a bit of sphere, simply because you've deflated the eye. Obviously, there's no discomfort. There's no wound to speak of. There's no external wound to speak of. But I will say this: no? The post-operative course, post-stent, will really vary from patient to patient. No different from a trabeculectomy. Some will scar, some will do well regardless of the follow-up. Some will need needling. Some will need adjunctive 5-FU injections post-operatively. So it's very, very difficult to say. But overall, you're not worried about wound leaks, button holes, etc., with the stent.
Yes, I remember seeing a paper. Yeah, I remember seeing a paper years ago that said that TCCE and phaco were equivalent because they both were correctable to 2020. But there are a lot of peripherals. It's not just the IOP in the end.
Yeah, but one of the things that struck me early on, Norman, when you gave your talk, what you said, if the pressure is very low post-trab, it's easy to deal with. I'm not so sure that's really a valid statement. Can you tell me, like, for example, if you have early hypotony, how do you deal with it?
That statement should be taken in this context. If I were presented with a hypotonic case in the first week of surgery, there are options or escalating options that I can choose. I can choose to dilate my pupil, to deepen my chamber, to physically step on my sclerostomy and scleral flap in order to contain the fluid. All right. So that's what I'm saying. There are pharmacologic options. If that doesn't work, I go to option 2, option 3, and maybe the last will be to reform actually on the OR table that hypotenuse eye. So I said that in the context that there is something that you can do and you can see the results immediately. So that was why I said that.
Yeah, because that would be one of the main reasons why MIGS is so attractive to a glaucoma specialist, because basically you avoid the possibility of hypotony in, I think, most of these cases. Is that true,
That's
Roman?
true. That's true.
Yeah,
I agree.
because the lumen size is uniform, no different from what Norman mentioned earlier about the size of the ostium of the express shunt. It's uniform. You cannot enlarge it. You cannot make it any smaller. So hypotony is basically non-existent now for MIGS devices that are inserted in the trabecular meshwork, all the more so. Because again, your hypotony will not exist if you have an episcleral venous pressure floor. It cannot exist.
Minimally effective. Anyway, so
no, I think there are no head-to-head trials comparing Sen and Trabec, but you do have case series, and there's a reasonable. Like one said, at 2 years, about 40%, little less than 50%, were able to maintain very low pressures, 15 below, which is not that far from what you get from Trebek, actually, I think.
Correct.
So
Yeah,
maybe one more question.
Go ahead. Go ahead, Alex.
Reoperation of stents often show remarkably thick fibrosis wrapping the implant. How do you apply antifibrotics? Do you inject more post-op? Is there a risk of getting it into the anterior chamber?
Um,
So
I've,
maybe we can ask
I've,
Romel this.
as I showed you earlier in the previous slides, I've only done essentially 2 cut downs with the stent. One was to repair a stent that extruded outside of the conjunctiva, and therefore had to be rushed back into the operating theater to repair and reposition the stent. You can apply. The other one was Dr. Alex. Remember a couple of weeks ago, I asked you to take a look at a case right before I started it, no? And I was asking your opinion whether I should do a legal-based flap or a foreign-based flap, and yes, we did apply. We did apply after removing the tenon. The tenons that was wrapped around the center. Oh, by the way, the scar doesn't really stick to the stent. All right, it doesn't really stick there like super glue. It basically just forms a sock over the tip of the stent implant, which prevents it from.
Okay, I think there's a question from the audience. What do you think of MIGS for pediatric glaucoma? Anybody?
We're not yet there.
Okay.
We are not yet there.
But in theory, is it an option?
In theory, yes. In theory, yes. But like I said,
and trabeculectomy is practically just the same as when you do your knife. You know, that's what you do when you do a trabeculectomy.
Correct.
So
but,
instead of
if they're referring to subconjunctival devices like the pressure flow or the send, then we're not yet there. I don't think we'll ever get there. I think that's a bit dangerous, to have that foreign body there as the child is growing up. But yes, you're absolutely correct, Dr. Chella. Trabeculectomy is basically that. It's basically the Cahoop blade in a fashion.
And it works, and it's your first line of choice for congenital glaucoma. So why not do that in congenital glaucoma? What do you think, Alex?
Actually,
Alex seems to be frozen.
I think his mic is off.
Yeah.
Oh,
Yeah. No one has Alex.
He's frozen.
So,
wala.
so is there any other question? If not, I think it's about 7. We thank everyone for your questions.
Thank you.
And of course, we'd like to thank our speakers who generously elaborated on each concept for better understanding. I hope that we were able to enlighten you more with the different presentations and cases that we showcased today. And since that was the last question from our viewers, so this has been a great learning and hosting opportunity. And I would like to thank TMC EyeTV once again for inviting me for the next episode of TMC EyeTV. Join us again for the 12th episode at 5 p.m. on November 5, where we will be shifting our attention to the medical management of glaucoma, highlighting the importance of preservative-free glaucoma medications for our patient. Alex?
Oh, our number of subscribers continue to grow. Thank you for staying with us since the beginning, as always. Don't forget to click the thumbs up, subscribe, and hit the bell icon below to get notified whenever we release new videos from our YouTube channel.
A big thank you once again to Allergan for partnering with us on this episode. And of course, many thanks as well to our speakers, Dr. Norman Aquino, Romel Bautista, and Carlo Rubio, for allotting time and sharing their expertise with us today. Finally, I would also like to express our gratitude to our attendees who joined us today. Once again, I'm Ted Gonzalez, and Alex seems to be frozen. I think he would also want to say thanks to everyone, and see you all again in the next episode of TMC EyeTV, Ophthalmic Instruction Without Borders.
Thank you.
Thank you.